Hello everyone and welcome to this powerful masterclass why you are still weak after injury, the muscle loss, deconditioning and how to rebuild strength safely. So if you've ever felt frustrated that your strength hasn't bounced back after an injury, surgery or even a long recovery period, this deep dive is for you. Whether you're recovering personally, supporting someone who is, or a health practitioner guiding patients, we will unpack the real science behind persistent weakness. And the most important, the safe, evidence-based way to rebuild it. Let's get stronger together. So after an injury, whether fracture, ligament tear, surgery, or even just weeks in a cast or a bed rest, it is common to feel significantly weaker long after the pain subsides. And studies show that muscle strength can drop dramatically and recovery isn't automatic. So after an injury, whether you got a fracture, a ligament tear, surgery, or even just weeks in a cast, or you had bed rest, it is common to feel significantly weaker long after the pain has subsided. And studies show that muscle strength can drop dramatically and recovery isn't automatic. For the general audience, you can imagine your muscle as engines that shut down when not used. Just imagine your muscle as engines that get shut down when they are not used. They get rusty, they get smaller and less powerful. That's what muscle atrophy and deconditioning in action means. For the health practitioner, we can say that post-injury weakness stems primarily from disuse atrophy, which is a physiologic and sometimes neurogenic factors that leads to reduced cross-sectional area, impaired muscular activation, and systemic deconditioning. It is reversible in most cases with targeted intervention, but delays can prolong deficits. So what is atrophy? Atrophy is decrease in the cell size and number of cells, decrease in the cell size and cell number. So what happens is that post-injury weakness will always occur from disuse atrophy, which is the decrease in the cell size and the cell number, which we call a physiologic atrophy. And sometimes the neurogenic factors will also lead to reduced cross-sectional area, will also reduce to impaired neuromuscular activation and systemic deconditioning. This is always reversible in most cases with targeted intervention, but delays can always prolong the deficits. So we'll uncover why this happens, the mechanisms, the timelines, and the proven steps to rebuild safety, and no rushing, no re-injury, stick around. So injury forces rest or immobilization. Injury forces rest or immobilization. Let's look at what happens to your muscles after injury. What is it that happens to your muscles after injury? Injury forces rest or immobilization, and the muscles hate inactivity. Your muscles hate inactivity. Within days, they start shrinking. They start shrinking within days. A simple explanation is that think of muscles like the unused plants. Without water, they wilt and shrink. Without water, the plants will wilt and shrink. So those are your muscles. If they are not used, you have said that the muscles usually hate inactivity, and within days they will start shrinking. So for the practitioner, we can say that disuse atrophy occurs rapidly. It always occurs rapidly. The muscle mass can drop 3 to 5% in the first week, 3 to 5 3 to 5% in the first week of immobilization, with the strength losses up to 20% or more in 2 to 3 weeks. The lower limbs often lose faster. For example, the quadriceps will always lose up to 8 to 10% in shorter bed rest. The mechanisms include reduced protein synthesis. There is reduced protein synthesis, increased breakdown via the ubiquitin, proteasome, and the autophagy pathways, and activation of atrophy genes like the atrogene 1, the MAFBX, and the MURF1. So that is what happens. And deconditioning will add cardiovascular and neuromuscular decline, making everyday task feels exhausting. So for the practitioner, I have talked of disuse atrophy. Disuse atrophy always occur rapidly with immobilization. For example, the muscle mass can drop between 3 to 5% in the first week of immobilization. So what happens in the first week of immobilization? The muscle mass usually drop from 3 to 5% in the first week, with the strength losses up to 20% or more in the next 2 to 3 weeks. And lower limbs are usually affected, and they often lose the muscle mass and the muscle strength faster. For example, the quadriceps muscle, they can lose up to 8 to 10% in a short bed rest. The mechanisms here that lead to the loss in muscle strength and the muscle mass usually include reduction in the protein synthesis. Remember, the muscles depend on the proteins. So there is reduction in the protein synthesis, there is increased breakdown via the ubiquitin proteasome, and then autophagy pathways. Autophagy basically means self-destruction, self-eating. The autophagy pathways and activation of the atrophy genes like the atrogene 1. Then this, if added with deconditioning, they will add cardiovascular, the respiratory, and the neuromuscular declines, which make everyday tasks feel exhausting. So that is what happens to your muscles after an injury with immobilization and rest. So let's look at the science behind persistent weakness. Let's look at the science behind persistent weakness. So why does muscle weakness linger even after healing? Why does muscle weakness linger even after treatment? Even after healing, why does muscle weakness linger even after healing? It's not just the injury, it's how the body adapts or maladapts to issue. It isn't just about injury, it is about how the body adapts or how it maladapts to the disuse. The key mechanisms here, we have muscle atrophy. Number one, we have muscle atrophy. The proteins breakdown outpaces the synthesis. So muscle atrophy, I have talked of decrease in the muscle size, decrease in the cell size and cell number. So with muscle atrophy, there is protein breakdown which will outpace the synthesis that is required. So there is protein breakdown which will outpace the protein synthesis that is required. So that is the first mechanism, muscle atrophy. The second mechanism, we have atherogenic muscle inhibition. Atherogenic muscle inhibition. So swelling or pain shuts down the muscle activation via neural reflexes. If you develop swelling or pain, it will shut down the muscle activation via your neural reflexes. That is what we call the atherogenic muscle inhibition. Then the third mechanism, we have neuromuscular changes. This will lead into reduced motor unit recruitment or firing rates. So the motor unit is whereby the muscle, the nerve supply of a muscle develops from. There is reduction in the motor unit recruitment and firing rates. That's what happened with neuromuscular changes. Then systemic deconditioning. There's loss of endurance, balance, and coordination. Loss of endurance, balance, and coordination. That comes with systemic deconditioning. So that is what happens. That is the science behind persistent weakness. Those are the key mechanisms, the four key mechanisms. I have talked of muscle atrophy, atherogenic muscle inhibition, neuromuscular changes, and systemic deconditioning. So an easy analogy here, we can say that your muscles are like a smartphone on an airplane mode. Your muscles are like a smartphone, but in this case, it is on an airplane mode, and it is still there, but not connecting or charging properly. It is not connecting to the internet or not charging properly, and over time, the battery, which is the strength, drains later. So that is the easy analogy that we can say. For the practitioners, for the general practitioners, we can say that disuse suppresses the motor signaling, which is the anabolic, while activation leading to autophagy, which is self-eating, autophagy-mediated proteolysis. So inflammation and oxidative stress amplify this. In older adults or in severe cases, the satellite cell dysfunction impairs regeneration. Strength loss often exceeds the mass loss due to neural factors. The strength loss will often exceed the muscle mass loss due to the neural factors. Those are the mechanisms of, that is the science behind the persistent weakness. The mechanisms, the four key mechanisms are the main thing at this point. Number one, we have muscle atrophy. Number two, we have atherogenic muscle inhibition. Number three, we have neuromuscular changes. Then number four, systemic deconditioning. Now let's look at the factors that make weakness worse or better. So not everyone loses the same amount. Not everyone will lose the same amount of muscle strength and muscle mass. Age, nutrition, and activity also matter. Not everyone will lose the same amount of muscle mass and muscle strength. Your age, the nutritional intake, and the activity levels always matter. The worsening factors include prolonged immobilization, poor protein intake, inflammation, and older age, which will slower recovery, and also fear of movement, which is known as kinesiophobia. You are afraid of movement. So those are the worsening factors: prolonged immobilization, poor protein intake, inflammation, older age, which will slower your recovery rates, and fear of movement, which is kinesiophobia. Then the beta factors, here we have early gentle activation, adequate protein to stimulate the muscle, and also the resistance training synergy. So those are the beta factors. We have early gentle activation, adequate protein, and resistance training synergy. So a simple tip here is that nutrition is huge, and protein post-injury helps preserve the muscle mass. Nutritional intake at this point is very important, and your protein intake post-injury will help preserve the muscle mass. So for the practitioner, we can say that evidence has shown that protein supplementation and early rehabilitation synergy to encounter disuse. Evidence shows protein supplementation plus early rehabilitation synergize to counter the disuse atrophy that occurs. Progressive loading, for example, 10 to 15% weekly increases, optimizes adaptation without overload. Acute chronic workload ratios of 0.8 to 1.3 is safest. So always progressive loading is advised. Progressive loading is advised as it optimizes the adaptation without any overload. So what are the factors that make weakness worse at this point? The worsening factors we have talked of: prolonged immobilization. So if there is prolonged immobilization, poor protein intake, inflammation, older age, and fear of movement, which is kinesiophobia. And the beta factors here we have early gentle activation, adequate protein, and resistance training synergy. So those are the beta factors that help with weakness. Early gentle activation with the guide of your physical therapist and resistance training synergy, also with the aid and with the guidance of your physical therapist. Then adequate protein intake. So the simple tip here, I've said that nutrition is huge at this point. And protein post-injury will help preserve the muscle mass. Protein post-injury helps preserve the muscle mass. So how do we rebuild the strength safely and what actually works? So rebuilding is progressive, it is phased and supervised when possible. So rebuilding your muscle strength is usually progressive, which means it is step by step, and it is phased, which means there are phases. Then it should be supervised when possible. Supervised by your physical therapist. So the phases here we have protection or early intervention, then we have the strength foundation and functional progression. So the first phase is protection or early activation. The first phase is protection or early activation. So this is the point where we only engage on isometric exercises. So isometric exercises, this whereby there's no movement of the muscles. There's no movement of the muscle. What happens is that there is contraction of the muscle. There's gentle contraction of the muscles. For example, mm, for the quads, what we usually do, we can use our hands or a towel. And what happens is that the quads, what happens is that we put the towel underneath the quads and the patient pushes the towel downwards. As they push the towel downwards, what happens is that the quads will contract. That is for the knee joint. The quads will contract, and as they contract, we protect the muscle strength and the muscle tone and muscle mass. So that was on the first phase, protection or early activation. We have the isometrics, we have the gentle range of motion exercises to fight. We have the early gentle range of motion exercises to fight the atherogenic muscle inhibition, the AMI. That was on the first phase, which is protection or early activation. Then the second phase, which is strength foundation, this is whereby we include body weight, where we progress to resistance. For example, here is where we can have the quad sets, we can have the straight leg raises, we can have the bridges, and so on. So this is the strength foundation. The focus is on improving the muscle strength. And what we do is we use the body weight and we progress to resistance. Always progressive resistance. We use the quad sets, we can use the straight leg raises, we can use bridges, we can use lunges, and many others. Then we progress to functional progression. In the functional progression, this is whereby we use load bearing, we use balance, and sport specific. So the proven strategies are that you start slow, you go slow, and you do gradual overload. Start slow, always start slow, go slow, and use gradual overload. Incorporate resistance training 2 to 3 times a week. That is why we have talked of the second phase of the strength foundation. Incorporate resistance training 2 to 3 times per week. Then you can use tools like TheraBands. You can use water exercises for low impact. What we usually use, since not all people will have access to the hydrotherapy, we usually use the TheraBands. We usually use the TheraBands, the bands. Then nutritional intake should be between 1.6 to 2.2 grams of protein per kilogram body weight. Then for practitioners, we always use evidence supports eccentric focus later. NMES, which is neuromuscular electrical stimulation for severe cases and monitoring pain-free progression. So you can always use things like TENS and the NMES, which is neuromuscular electrical stimulation for severe cases and monitor pain-free progression. So examples that we can use here, we have quadriceps for the knee joint. We can use calf raises for the ankle joint. We can use shoulder circles for the upper body. So that is how to rebuild the strength safely. I've said that rebuilding should be progressive. It should be phased and supervised by a physical therapist when possible. In the phases, we have the protection or the early phase, we have the strengthening foundation and the functioning progression. And the strategies here, we say you start slow, you go slow, then you do gradual overload. Always within the exercise activity or within the program, incorporate resistance training at least 2 to 3 times a week. Then we can use tools like the bands, the TheraBands. The nutritional intake should be monitored of 1.6 to 2.2 grams of protein per kilogram body weight. Then we can also, in severe cases, we can also monitor and use things like neuromuscular electrical stimulation and TENS as we monitor for pain-free progression. So weakness after injury is normal, but it is fixable. It is normal, but it is something that can be fixed. And muscle loss and deconditioning happens fast. Muscle loss and deconditioning always happen fast. But with smart progressive rebuilding, you can come back stronger. You can always come back stronger. And for the general population, always move early, move safely, fuel properly, and be patient. Always be patient. Do not expect one-time results. For the practitioner, you can prioritize early intervention and progressive loading for optimal outcomes. Always prioritize early intervention and progressive loading for optimal outcomes. So you've got the science and now you can take action. You can drop your recovery story or question below. Smash the like button if this helped. Subscribe for more content and share with anyone who is rebuilding. Strength is coming back and let's go for it. See you next in the next video. Thank you.